Hey ResusXers, Salim Rezaie here, and I posed this question online a few weeks ago. Should we give sodium bicarbonate in diabetic ketoacidosis? And as you can imagine, I got some really polarizing responses to it. But let me just set this up with a hypothetical patient. Adult female patient with type 1 diabetes mellitus ran out of her insulin and presents with DKA. Here's her initial labs: pH of 6.6, a serum bicarbonate of 1.5, a CO2 of 19, an anion gap of 29, a potassium of 7.2, a glucose reading greater than 1,000, respiratory rate in the 50s. This patient is obviously Kussmaul breathing, and hypotensive with a blood pressure of 90s over 50s and a GCS of 9, completely altered patient. Now, I presented that exact scenario on both X, which used to be called Twitter, and on my YouTube channel. And as you can see, the majority of people actually said yes, but the people who were actually responding were pretty strong in their intent of no, we should not give bicarbonate. Now, the purists among us might say for physiologic reasons, we should not be giving bicarbonate because it's only going to make the patient more acidotic. The evidence-based medicine answer is there's no high-level evidence to give bicarbonate. Here's my responses to that. So from the physiologic standpoint, yes, it's true. If we give bicarbonate to patients, that will bind with hydrogen and become H2O as well as carbon dioxide. And when you have a patient that's breathing in the 50s and already acidotic, you are potentially going to make them more acidotic. But how many things have made physiologic sense in medicine that only when it came time to study them, it turned out that it wasn't the case? And that's because humans are complex. It's not as simple as equations that we learned in school. Now, as far as the lack of evidence for sodium bicarbonate, here's my answer: an absence of evidence is not evidence of absence. With that being said, keys to all DKA patients: insulin, insulin, and more insulin. They need insulin. We need to give them time. We want to use balanced crystalloids, not normal saline, because normal saline can make them more acidotic. And then it depends on the mental status of the patient. This patient has a GCS of 9. I would be concerned about vomiting and aspiration, so I would probably avoid BPAP. I would probably do something like high flow nasal cannula as a BPAP light to help with work of breathing, as well as help them blow off some of that CO2 by trying to improve some of their minute ventilation. I do not routinely use sodium bicarbonate in the management of my DKA patients. However, there are some scenarios where I consider it and I do use it. So if I have a patient with a pH of less than 6.9, now that number by itself will not push me to use sodium bicarbonate. They have to have one or more of these things I'm about to list. Hyperkalemia with or without arrhythmias, which in this patient, her potassium was 7.2, and I'm not saying it truly was 7.2, it was probably falsely elevated, but when it comes down to it, I'm going to treat the patient in front of me. Hemodynamic instability, even with fluids and pressors. So this patient had already gotten 2 liters of lactated ringers and still was remaining hypotensive, to the point that we were starting a norepinephrine drip to support the hemodynamics. And I think when you have a peri-arrest or cardiac arrest patient, all bets are off. At that point, I'm going to do whatever I can to buy myself a little bit more time to get that patient back. Now, what is the best way to give sodium bicarb? Now, most people think when I'm posing that question that I'm implying that we should be giving crash cart bicarbonate, which is 8.4% sodium bicarbonate. This is the equivalent of 6% normal saline. It's a 2,000 milliosms per liter solution that you're giving. Now, we don't have this readily available to us in the United States, but there are a lot of places in Europe that have this kind of half concentration sodium bicarbonate, which is 1,000 milliosms per liter, which is 3% normal saline, right? It's like giving hypertonics to a patient with increased intracranial pressure. The way I like to do it is I like to take 3 amps of bicarb and put it in 1 liter of D5W. This is the equivalent of 300 milliosms per liter, right? This is like doing 0.9% normal saline. It's a more isotonic solution until I have my patient more stabilized and looking better, giving my insulin time, my lactated ringers time, and then I turn it off. Should we give sodium bicarbonate and DKA? I'm going to tell you in 95% of the cases, the answer is no. If the pH is less than 6.9 and they have any one of these things, hyperkalemia with and without arrhythmias, hemodynamic instability even with fluids and pressors, or the patient is peri-arrest or cardiac arrest, then I would consider giving bicarbonate, but not in the way that we typically do, which is crash cart bicarbonate. I would mix my 3 amps of bicarbonate, put it in 1 liter of D5W, and I would run that at 100 to 150 cc's per hour until my patient is a little more stabilized. So there you have it. Would love to hear your thoughts, comments, and questions. I hope this kind of stirred some debate amongst you in the room, and I'm sorry I couldn't be there, but Haney, thank you for the invitation, and I hope this gets some controversy going in the room.